Okay, so I'm going to be talking about shoulder joint today. I mean, I heard already talked about it, I think, but I'll try to get into the details of it. So, mostly in the sense, I'll be talking about the stabilizers, the joint stabilizers, and probably I'll try to get into some of the dislocations as well. So now, um, right. So shoulder joint is articulation between the head of the humerus and the glenoid cavity. So that's the scapula. So it's the articulation. So it's a synovial ball and socket joint. So what you will have is a capsule, membrane, synovial joint space, two articular surfaces, hyaline cartilage, fluid filling that. So that is basically the shoulder joint. So right. So now you know the shoulder joint and the yeah the basically the joint. So now come to the stabilizers. Stabilizers, now you can talk about static as well as dynamic stabilizers. Static in the sense they are not moving, dynamic they are moving, right? Static stabilizers, you can talk about the bony aspects, the ligaments, the bony aspects and ligaments, mostly those two, right? And the capsule also you can just add in there always. And another one now after that is the dynamic stabilizers where you'll mostly be talking about the muscles. So come to the shoulder joint static stabilizers. So we know the glenoid cavity is a nice, fit to the anatomical head of the humerus. So we can say that. So that bony, that articulation is very nice, and the labrum enforces that. It makes a much better cavity. So that is one. So the labrum and the cavity. So we talked all this talked said the capsule is something you can say. Now the ligaments. Ligaments means we'll talk about the glenohumeral ligament, which can be superior, middle, and inferior. Now of these three, the inferior one is the strongest. So that is, so the glenohumeral ligament from the glenoid cavity, glenoid region to the humerus. Another one is the coracohumeral acromial clavicular. So again, the one that goes up, like a three-way upwards. So that's one thing you can talk about. Then you can yeah. So those are your ones. Then yeah, then you have your coracoacromial arch is also there. That again superiorly, it's very less unlikely to be dislocated. It is unlikely because you have the acromioclavicular joint again above, right? So these are your static stabilizers. Now come to the dynamic stabilizers. It's basically your rotator cuff muscles and your yeah the rotator cuff muscles. So the rotator cuff muscles, that is, the pneumococci sits, meaning supraspinatus, infraspinatus, teres minor, and subscapularis. So these are muscles you can say. So these are your what you say your dynamic stabilizers. Don't forget you can also add the long head of biceps as well. So with that being said, we have covered the static as well as dynamic stabilizers. So now we have talked about the joint stabilizers, and most the common thing, clinical thing you would want to know is that anterior dislocation is the commonest dislocation, 80 to 90% of the time, and you can use the coach's maneuver to do this relocation. And if you have something like a posterior dislocation, you have to do something of a modified coach's maneuver, because if you do the coach's maneuver in a posterior dislocation, you have a risk of fracturing the humerus because of the force that you're putting, right? The moment can fracture the humerus. So then, now if you were to look at the presentation, let's say for anterior shoulder dislocation, how would the patient look like clinically? Now let's say a patient is coming to you. Now how would this patient look like? That is something you would want to ask, right? So right. So when the patient's shoulder is in the front, right, so the anterior muscles are relaxed, so now you are pulling from the back. There's pull from the back. So what you have is abducted shoulder and externally rotated hand, extra arm, right? So the arm is somewhat abducted and externally rotated. So that is the presentation for an anterior shoulder dislocation, because the pull from the back is much stronger. Now, let's say you come with the posterior dislocation, the dislocation from the posterior spine. Now, there's pull from the anterior side is much stronger. So, what's going to happen? The pectoris may adduct and internal rotate. The hand is going to be adducted, internal rotated. That's pretty much the straightforward thing. If it is much inferior dislocation, the delta is going to pull it up. So, it's going to be abducted, right? Abducted hand. So these are the things you have to keep in mind, and complications could include neurovascular compromise, extraneurovascular in close proximity on the region. So it's an emergency. So you have to immediately relocate, otherwise, compromise is possible. Right? You can, if it's dislocated once, there's a tendency it can be relocated. It can dislocate again. Then you might have to go for different other types of some repair. Then yeah, usually, so let's say, yeah, this location you are relocated, you want to keep the patient on a broad arm sling for about 4 to 5 weeks. And yeah, if it happens again, if they do not follow the protocol, it might happen again because of poor healing, but sometimes it might happen nevertheless. So follow up and see how the patient proceeds, and just the initial management is very important. You want to relocate it, you want to avoid the dislocated position because of the tendency to be compromised. All right.